Hello and welcome. My name is Andrew Conway Morris. I'm an intensive care consultant and researcher at the University of Cambridge, and I am the medical director for Sepsis Research, FEAT. I'm here today to have a discussion with Beth, who's a sepsis survivor, about what sepsis means both as a clinician and professional, but also to patients and survivors.
Hi, so I'm Beth Budgen. I'm on the board of trustees for Sepsis Research FEAT, and I have lived experience of sepsis. So Andrew, from my perspective, before I contracted sepsis, I had heard the term, but I didn't really know what it was or indeed how deadly or the impact it could have on people's lives.
So I think that's very common. I think even until a few years ago, the term sepsis was not really widely used in the general public. It was a medical term. And whilst there has been increasing awareness of the term, what it actually means is often poorly understood, and unfortunately even by some healthcare professionals too. So sepsis is where an infection develops into a severe response. It's the body's response to that infection that causes sepsis. And it's where that response leads to the organs being damaged, so your lungs, your heart, your kidneys, your liver. And clearly, if that progresses, that can make you severely unwell, and if that process is not arrested, ultimately can lead to the death of the patient. So it's very, very serious when someone develops sepsis, and it can develop very, very rapidly, and we need to be able to intervene fast to try and arrest that process, or to support life whilst we're waiting for the treatments to get working.
So Andrew, what would you say are the key symptoms that members of the public should be looking out for?
Sepsis is a real challenge because it can present in so many different ways, and it arises from lots of different infections. So some of those symptoms will be from the infection itself. If it's in your lungs, like a pneumonia, you may get more lung symptoms, cough, sputum, pain in the chest. If it's arising from the urinary tract, from the kidneys, you may get more urinary symptoms. But the sort of common features that you see in all patients with sepsis, or many patients with sepsis, are those sort of features of organ failure. So often we'll see very high temperature, but also sometimes a very low temperature, increased respiratory rate, so breathing faster, rapid pulse, cold peripheries, so the hands feeling cold even when someone has a temperature, mottling and rash on the skin, reduced consciousness or increasing confusion, reduced passing of urine. So if someone hasn't passed urine for many hours, 6, 12 hours, that's clearly unusual. But all of those are not necessarily specific to sepsis. They can occur in any severe illness. They're features of a severe illness. Ultimately, I think the best sort of test is, do you or does your relative or friend appear more unwell than they ever have done before? It's that sort of, I feel absolutely awful. This is not, all of us have had infections. All of us have had flus and chest infections and skin infections and so forth. So we all know what that feels like. But it's that, no, this doesn't feel like that. I now feel really, really unwell. And I think that's the critical thing to look out for, because it's different from, someone has a heart attack. We all sort of know what that's, what that looks like, that sort of central crushing chest pain radiating down the arm, or a stroke, and there's lots of public awareness about that. You're weak down one side, you can't find words, droopy face and so forth. They're sort of relatively straightforward to spot. And sepsis is just different because it doesn't have that, single or unifying group of symptoms. So it's about trusting your instincts. How do you feel? Or knowing your relative, your friend, your child, and saying, this is just not normal for them. And I think the other thing we have to be really careful, people are often worried about approaching medical, seeking medical advice and seeking medical help because they don't want to put a burden on the health service. They don't want to be trouble and so forth. And that reluctance is often, unfortunately, something that holds people back from seeking attention when they need to. And so whilst, it's absolutely true that the NHS is under significant pressure and primary care especially, and there's no denying that. But if you're feeling unwell, this is life or death. This is extremely important, and one can deteriorate very, very rapidly. And we would much rather, as healthcare professionals, see someone, reassure them that things are okay, safety net, say these are the things to look out for if you get worse, than have someone, sitting at home deteriorating to the point where they become unsalvageable or spend much, much longer in the intensive care unit or similar. So, look out for those symptoms, seek early medical advice, and don't be afraid to ask. And ask yourself the question, ask the healthcare professional the question, could this be sepsis?
So, Andrew, what would your advice be for somebody who had presented to a medical professional and had been turned away because they weren't deemed to be ill enough?
So that's a really, really good question, because that's a really challenging area. As we've sort of already discussed, sepsis is really difficult to pick up, even for experienced healthcare professionals. And particularly in the early stages, it may be indistinguishable from a sort of common or garden infection, an infection that isn't going to turn into sepsis. And things can change. It's a dynamic process. And particularly, for me, I'm in a very privileged position of working in an intensive care unit where I can come back and see a patient multiple times. I have a nurse at the bedside 24 hours a day keeping an eye on them, so I can watch for trends. But if somebody's attended an emergency department or a general practitioner, they haven't got that luxury. So the only safety net we've got there is the patient themselves and their carers or those around them, spotting if they get worse and bringing them back. And again, as we were talking about, people's reluctance to present for medical attention, there's often an even greater reluctance to re-present. You think, well, I've already seen the doctor. They've told me everything's fine. I'm probably just being a bit silly. Well, again, you've got to trust your gut instinct. So I would say if you've attended hospital or a general practitioner because you think you have a severe infection or because you feel unwell, you've been reassured, the first thing to do before you leave is to ask, what should I look out for? Now, almost all healthcare professionals will do what we call safety netting. They will already do that. They will say, these are the things to look out for. This is when I want you to come back. But sometimes, it's busy. They've got, trying to look after multiple patients and so forth. So there's never any harm to prompt that and say, what should I look out for? If this were to get worse, if this chest infection that I have were to turn into sepsis, what might happen? What should I do? And look out for those things. And again, it's exactly the same symptoms as we were talking about before. It's the reduction in consciousness, the reduction in urine output, the cold peripheries, the mottling, increased respiratory rate, uncontrolled shivering, and so forth. So looking out for those symptoms, and again, looking at the patient, especially if you've been with them, you saw them before, they look worse now, this is not a good thing. So again, whilst I think, again, people always worry about frequent attendance and frequent use and so forth, the reality is the vast majority of people err the other side, as in don't come back when they should do. And yes, we all have to be responsible users of the health service, and we all have a responsibility to ensure to our fellow citizens that we're not abusing a service, clearly. But actually, I think the far greater problem is that we're reluctant to seek that further advice. So don't be afraid to represent. Clarify with your healthcare professional what symptoms to look out for. What should I do if I get this? And if you're unsure, come back, ask for not even a second opinion, just a second review.
Andrew, when I contracted sepsis, I was perfectly fit and healthy. It's pretty terrifying how indiscriminately it can strike.
No, absolutely. And of course, this is one of the features of sepsis, is that it can unfortunately affect anyone at any age. Because it arises from an infection, and infections are very common, it can be pretty indiscriminate as to who gets attacked. And there's no group of people who are immune to it, let's say. Clearly, there are groups of people who are at greater risk, those at the extremes of age, so the very young and the very old, those who have medical conditions, particularly those with sort of immunocompromising medical conditions, are more likely to. But this is more likely, not definite. And as you say, people like yourself who have absolutely no medical problems at all in the past can be struck down by it. And that's why it's really important to look out for it. And again, I think we often, like with other things such as strokes and heart attacks, we often think of older people are more likely to, and if I develop central crushing chest pain, I'm probably just at the age where I should start worrying about it. But generally speaking, I think it's probably just indigestion and it's all right. Because I'm otherwise fit and healthy. And I think that's the thing with sepsis is like it can strike at any age. And if you feel any of the symptoms, the stuff we've talked about, seek urgent medical advice. Don't think I'm going to be all right because, I'm a sort of, regular person, doesn't take any medications, does a bit of exercise, looks after myself, doesn't drink too much sort of thing. Unfortunately, that doesn't protect you against sepsis. It's a really indiscriminate killer, and it's about being alert, thinking about it, and realising that it can strike anyone at any time.
Andrew, in my situation, I'd had a cold for a couple of weeks and just felt slightly unwell. We realised it was becoming worse when I developed a really bad pain in my left-hand side. Shortly after that, I began to vomit blue liquid.
So it's, I think this is again is the one of the challenges with sepsis is because it can arise from almost any infection, and it can arise at different points in that infection process. So, whilst generally speaking, viral infections don't lead to sepsis. Obviously, there are exceptions to that. COVID-19 was a clear example, and severe influenza is another example. But most of the time, those sort of upper respiratory tract cold-like symptoms are unlikely to develop into sepsis. But they leave you susceptible to secondary bacterial infections. Yeah. And they can come on. So you think, well, I've been unwell for the last couple of weeks. This is probably just a continuation of that. No, it isn't. And it's looking out for that change. I think it's that change in character which indicates the body's changing response. So it's gone from dealing with a cold, a sort of upper respiratory tract infection in this example, to suddenly dealing with a secondary bacterial infection. And as that immune response, it's your body's immune system that's ramping up to try and fight it, it starts fighting your organs at the same time and damaging the organs. And that's what makes you feel unwell, because clearly if your organ function is impaired, then that's critical to life. And that's how we experience it as ourselves. Those symptoms are essentially those symptoms of organ failure. And that can happen very, very quickly. And as you say, with exactly in your example, you go, well, I've had this for a couple of weeks. Why am I suddenly feeling more unwell now when I should be getting better? Well, that's again another sign to look out for. It's that step change. It's almost like a phase change, like going from solid to liquid. It's sort of everything's ticking along, and then suddenly it isn't. And it's watching out for that and going, right, I need to go and find a doctor, a medical professional urgently, and deal with this. And getting, particularly obviously, sepsis can arise from different organisms, bacteria, viruses, fungi, and parasites. In the UK, most commonly, or worldwide, most commonly, it arises from bacteria. And the treatment of choice there is antibacterials, antibiotics. So getting antibiotics in quickly is really important. And that again gives us another challenge because we're stuck between, we all know the risks of antimicrobial resistance, antibiotic resistance. I mean, it's, a bigger pandemic than COVID-19 and a bigger threat to human health than almost anything else beyond probably climate change. And yet, at the same time, antibiotics are absolutely life-saving and need to be given rapidly and quickly in patients who've got sepsis. So again, this is a challenge for healthcare professionals. It's a challenge for members of the public as well, because people think, well, I want to get better. I'd like some antibiotics. Well, absolutely, but only if they're going to work. So only in bacterial infections or in severe infections when it's difficult to tell. So to my sort of personal practice, I sort of divide people on a quadrant where you go, if you've got clear bacterial infection, we should treat that with antibiotics. If you're very, very unwell and we're not sure, but there's a likelihood that this could be a bacterial infection, we should give antibiotics because the risk is too great to miss it. If somebody is less unwell and the probability of infection is lower, then we then have the opportunity to sort of come back, re-review, say, look, if these symptoms develop, come back, and so forth. So we can put people on that quadrant, and that helps us use antibiotics wisely. But when someone is very, very unwell, it's really important, get to hospital quickly, present, and assuming that the professional who's seeing you thinks it's appropriate, getting urgent and rapid antibiotics.
So, Andrew, I think probably a lot of people would like to know, both family and medical professionals, how they might better identify the possibility of sepsis.
So again, another really good question, and it remains a real challenge because of this non-specific way in which sepsis can present. I think, obviously one of the things that sepsis research is doing is trying to find better ways of diagnosing it, but that's still at the research stage. So where we are at the moment, the best things we can do is awareness and being assertive. Asking the question, could this be sepsis? Saying, I feel more unwell than I ever have done before, or my friend, relative, child, this is the most unwell I've ever seen them. I'm concerned this might be sepsis. And again, not being afraid to go back and challenge is perhaps too strong, but just to sort of clarify and say, look, are you comfortable that this is not sepsis? It's saying, and if we are happy that at the moment we've just got a simple infection and nothing, unduly concerning, what should I look out for? What symptoms do I need to worry about? It's about being an informed patient, being, and informed patients are the best patients. You've got to be your own advocate. Or advocate for those around you if they're not capable of doing so, if they're too young or too confused and so forth. So I think ultimately it comes down to recognition and awareness. It is certainly clear that over the last decade, the awareness of sepsis has improved markedly amongst healthcare professionals. It's now something that is widely talked about, and that's a tribute to the many people who've been driving that agenda forward over the last really 15, 20 years, certainly that I've been practicing in. And it's gone from being a relatively poorly understood area to at least one where I think, you would struggle to find a healthcare professional who couldn't give you a good definition of sepsis and, would be aware of how it's likely to present. But even with that awareness, you can still miss it. So I think it's about awareness from both sides, both the patient and their relatives and friends, and from the healthcare professionals, working together to make sure we don't miss it, not being afraid to re-review, come back and see the situation again because it's a dynamic process, and acting quickly when it's suspected.
So many people that are lucky enough to survive sepsis can end up with either life-changing amputations, as in my case, but there are also a lot of other long-term side effects.
So one of the real challenges with sepsis, and something that I think has had less focus on than the early phases, the acute stuff that we've been talking about, the early recognition, early treatment, all of the stuff that we do in intensive care and so forth, there's been a lot of, very rightly, been focused on that, but less so on what happens to those like yourself who do survive and get through the acute insult. But as you'll be well aware, there's often a sort of long shadow cast after that. And like at the beginning with a variety of different symptoms, so the recovery phase can also be characterised by different symptoms in different people. So clearly in someone like yourself situation where you've had amputations and loss of limbs and digits and so forth, there's a sort of obvious rehabilitation requirement there that hopefully the NHS understands, and it's sort of, in some ways, it's obvious what needs to be done to help and so forth to get you back functioning again. But we often forget there's a whole load of unseen symptoms as well, and thankfully, obviously, the majority of people don't end up with amputations and loss of limbs and digits, but that doesn't mean they aren't left with serious symptoms. And those can be psychological symptoms, very common for people to experience what's called brain fog, a sort of difficulty concentrating, difficulty focusing on things. Mood changes are very common. Patients, especially those who've been through intensive care, often have quite unpleasant and intrusive memories of that, sometimes to the level of sort of post-traumatic stress disorder type thresholds. Depression and anxiety, very, very common afterwards. And of course, there's a whole collection of physical symptoms as well. So pain, muscle ache, fatigue, breathlessness that goes on often long after lungs have fully recovered. And the difficulty is we don't really understand what drives all those symptoms. Is there a single sort of common unifying mechanism that drives all of them? Or in fact, is the patient, different patients have different mechanisms driving that? And this has to be a focus of future research. Both on the biological side, can we find the mechanisms that are driving this? Is it persistent inflammation, persistent immune activation? In which case, are there treatments we could target towards that? But also, what are the most effective physical and psychological rehabilitation techniques? What should we be doing? What should we be doing in terms of speech and language therapy, in terms of dietetics, in terms of physiotherapy, in terms of occupational therapy? What works best in these situations? And how do we tailor it to the individual patient? And I think, again, I don't want to suggest that patients with other diseases are all the same. Sort of once you've had a heart attack, there's cardiac rehab. If you've got chronic respiratory disease, there's respiratory rehabilitation and so forth. But they are in many ways a bit more similar, and therefore a sort of relatively homogeneous rehabilitation can work for them, and does. Cardiac rehabilitation, well established. With sepsis, because people have so many different symptoms, it's really difficult to kind of design a package that works for everyone, and we've got to be bespoke. And unfortunately, that's difficult. I think the other thing that the NHS often struggles with is if there are clear pathways, it can work. But sepsis doesn't necessarily have a clear pathway for the post sort of hospital phase. Often be involved with a variety of different specialists depending on what organs have been damaged, maybe kidneys, maybe lungs, maybe prosthetics and physical rehabilitation. People who've been through intensive care, many intensive care units offer follow-up clinics, which can be very useful. But again, often relatively limited in terms of the ongoing rehabilitation that they offer, so much as a review of symptoms and sort of signposting to appropriate services. And people who haven't been through intensive care often don't have that at all. And so I think that can be a real challenge. How's best to navigate it really depends on the local health service you're in and the services that are available. Support from sepsis survivors charities can be really helpful, and talking to other people. I think sometimes just knowing that what you're going through is not, unique or strange to you. I think, especially a lot of the psychological symptoms, the vivid dreams, intrusive memories and things like that, knowing that this is really common, that this happens to lots of people, that you're not going crazy, so to speak, can be extremely reassuring. It doesn't make them go away. It doesn't make it any better in some ways, but it sort of says, well, these are things that happen, and in most people they will get better over time. That reassurance can be really helpful, and often that comes better from fellow survivors than I think it does from those of us who thankfully have not had to go through that experience ourselves. I think personally I was an advocate for better post-hospital and in-hospital rehabilitation for patients who've been through sepsis in the way that we do for other diseases. It is possible. The structures are there. Obviously, as ever, funding is a challenge. And again, I think these are things where, for the individual, what can the individual do? As much as possible, advocate for yourself and say, I have these symptoms. What can I do? Ask for help, and take advantage of the things that are offered. I know for some people, even just the contact from for those who've been through intensive care, even just the contact from the intensive care unit afterwards can be quite traumatic. It's a sort of, I really didn't like being there. I don't want to go back. And that's totally understandable. And of course, no one should be forced to do that. But I do know a lot of patients who do come back and get to see things, and it puts everything into context. They suddenly go, oh yes, when I was very, very unwell, I had this idea that there was a sort of giant clock that was ticking, and there was somebody else doing this, and now I see where that came from, because there is a large clock there, and there is a machine over there that makes that beeping noise, and it wasn't whatever I imagined it was, a gnome sitting at the end of my bed whistling a tune. It was an alarm from a ventilator. And putting that into context, sort of contextualize it, it can be really, really helpful. But I totally understand why people find, that even just the thought of going back to that just too much. And again, no one's going to force anyone to do that. It's sort of, but the nurses, the rehabilitation staff, units should have these. It's within the criteria for what we call the general provision of intensive care services, so the standards that are set out. But of course, we all know that the NHS has been under massive pressure, for the last sort of decade at least. And unfortunately, often those services are the ones that are perhaps the easiest to skimp on. So I acknowledge, I'm in a very privileged position of the place where I work, that we do have these services, and I know that not everyone has access to them. One of the things I think that Sepsis Research, FEAT, and other sepsis survivors and so forth can do is to make the case for why this is important, and to say, this is what we would need, because it's about getting people back up on their feet, getting back to work, getting back into social interactions. All of those things can be really, really challenging afterwards. And again, it's often not thought about. And it has a massive personal impact on those involved, but also it has a wider societal impact. If people aren't working, they're not, able to do as much as they were before. If people are more dependent than they were, they're and some of these things will be unavoidable. Sometimes people will be left in a situation where they are going to be more dependent than they were before. But some of that is correctable through appropriate rehabilitation, appropriate support services and so forth. And we should absolutely be doing that and getting people back to the best they can be after one of these devastating illnesses.
Andrew, how do we make breakthroughs in the understanding and treatment of sepsis?
So sepsis affects a huge number of people every year, both within the UK and worldwide, and has a significant mortality and morbidity burden. So both those who unfortunately pass away, but also that long shadow of post-sepsis recovery. And yet, despite this burden, the funding that goes to sepsis research is much lower than it is in other comparable conditions. And so this is a real challenge because sepsis is a public health emergency. We're seeing a lot of it. It's a major problem. And we've seen in other diseases how effective research can transform outcomes. Even in the relatively short period of my medical career, sort of 20-odd years, I've seen absolutely dramatic changes in outcomes from some forms of cancer, from heart disease, from strokes. I could go on and listing these things. And yet outcomes from sepsis haven't really improved all that much. I think most of the changes that we've seen, the apparent improvements, have come down to earlier recognition, but often that means recognizing people with less severe illness who are then appropriately labelled as sepsis, but of course were never likely to do as badly as those with the more severe illness. So I think a lot of the apparent improvements in sepsis outcomes up until now are almost artifactual. And the problem is that we just don't understand the fundamental mechanisms that underpin it. We know about infections, but how do infections become sepsis? We don't know. Why does that immune response, that inflammatory response, persist even after we've taken away the bugs? We don't know. How long does it persist for? Well, we don't really know that either. And so I think really, and obviously, as an academic who studies research, who studies sepsis, of course I might say this, but what we need to do is more research. But right through the process, so from susceptibility, why are some people more susceptible than others? Through early presentations, are there ways that we could pick it up even before people become more unwell? How can we pick it up when they are unwell, and how can we optimise early treatment? How can we deal with that acute inflammatory response while patients are often hospitalised or in the intensive care unit? And how can we improve outcomes afterwards? And it's across that whole spectrum of the patient journey that we need to study. And that requires, money, resources, people to take this seriously as a research priority. And that's one of the reasons why I'm so pleased that Sepsis Research has funded the James Lind Alliance priority setting exercise, where we've gone to patients, relatives, professionals, and the general public to say, what do you think the research priorities should be, for the next period of time? Where should the major funders put their money? Because there are, big funders in the UK. UK Research and Innovation, NIHR, National Institute for Health Research, Wellcome Trust, as well as smaller trusts and smaller funders such as Sepsis Research, and of course European funding as well. And so we need to say to these large funders, this is a priority. This is what the people who've suffered this think it's a priority. This is what the people who treat it think is a priority. Here are the projects. Now, let's get them going, and hopefully we'll see significant changes. I'm optimistic that we are on the cusp of some new understanding in sepsis in terms of both the biological underpinnings of it and pulling apart. I think one of the problems that we've always had is this non-specific presentation, but often because actually we tend to lump everything together and we call it sepsis, which is a useful concept, but actually it's not one single disease. It's not one single syndrome. It's a bit like saying, well, can't we treat cancer? And you go, well, yeah, but not with one single treatment, because a lymphoma is different from a bowel cancer, is different from a lung cancer. And in fact, even within those, there's a wide variety of differences. And sepsis is like that as well. There are not quite as many varieties of sepsis as there are patients, but there are definitely many more varieties than is clinically apparent from the end of the bed. And there's been some really exciting work on that over the last few years and picking apart what makes people susceptible to it. A lot of this work has been funded by Sepsis Research. But what makes people susceptible, what these different disease types look like. And none of them have quite yet got to, therefore we should give this treatment or that treatment. But that's not far away. So I'm really optimistic about the next sort of 5 to 10 years, and I hope that we will see major changes, and I hope that people in your situation in the future will not have to go through what you've gone through. If that's what we can achieve, that's what we should be aiming for.
Thanks so much, Andrew. It's great to talk to you as always, and we're absolutely thrilled to have you on board at Sepsis Research Feet. I think it's just been really useful so that people can not only more easily identify the symptoms of sepsis when it's far from easy to identify. The self-advocacy piece, I think, is absolutely crucial. And in terms of our conversation, obviously, this situation, this crisis, as you rightly say, is never going to get better without further research, which is obviously where Sepsis Research Feet, can lead the way. So thank you so much.
Thank you, Beth, and it's been an absolute pleasure to have this conversation with you. And thank you to yourself and to Sepsis Research Feet for inviting me along today to speak. I hope that those watching have learnt something from this. And as you say, I totally endorse that message. It's both the awareness is so important, that advocacy, the willingness to represent if things are getting worse or certainly not getting any better, but also the wider need for research in this area. It's absolutely vital. And as you say, it's a public health emergency. And if we don't do the research, we're not going to get any better.